Hello everyone, it is my pleasure and honor to meet you in this interesting conference. I would like to thank Lebanese Society for invitation. I will talk about the latest European Society hypertension guideline and the difference between the oldest one and the new one. And as you know, hypertension is a global epidemic. It's affected more than 30% of world population and around two-thirds of the living population in low income and middle income countries. New hypertension cannot be cured but can be treated effectively. And a recent guideline 2023 is a long series of high blood pressure clinical practice guidelines, and it is resembled to the 2018, and there is an incremental rather than a major changes. And this definition and classification and grading stages remain the same as 2018 guideline. There is no marked difference between the oldest and the new one. And the major difference in the guideline, who write the ESH guideline 2023? The recent guideline written by the European Society of Hypertension in collaboration with European Renal Association and International Society of Hypertension, while the oldest one written by the European Society of Cardiology and European Society of Hypertension. Difference number two, the class of recommendation differ. We did not subdivide the class 2 into A and B because add little value and for simplification and for conveying a clear message. And as you know, and shown in this slide, class 2 cannot divide it into 2A, 2B into an ESH guideline 2023. Difference number 3, there is a difference in pathophysiology background of primary hypertension. In addition to oldest one guideline, as they mentioned, the genetics factor, lifestyle factor, environmental factor, they added an immune inflammatory process factor and metabolism effect of the increase of blood pressure in pathogenesis. Difference number 4, the goal is not to reduce the blood pressure, not to select antihypertensive medication. And the criteria for to select antihypertensive drug as the base of therapy in hypertensive patient: one, a proven ability to reduce blood pressure as a monotherapy, evidence from randomized control trial that they reduce morbidity and mortality versus placebo, and in addition to favorable tolerability and safety profile. And the difference number 5 regarding the time of the antihypertensive medication ingestion, and they said either morning or evening, and recently and the last guidelines say no difference between whether morning or evening of taking antihypertensive medication, but should avoid diuretic at night. Difference number 7 regarding the risk stratification score, as the oldest one, Frankham study score system, but recently they recommended cardiovascular assessment with the score 2 and score 2 all population system recommended for hypertensive patients or are not already at high risk or very high risk due to established cardiovascular or chronic kidney disease. And this guideline, this risk stratification divided the hypertensive patient, the stages and the risk factor, and they found that stage 3 would establish cardiovascular disease or chronic kidney disease grade more than grade 4 is a very high risk, even in high normal or grade 1 or grade 2 or grade 3 hypertension. Difference number 7 related to the screening versus confirming the diagnosis, and they recommend case finding or opportunistic screening for hypertensive patient recommended in all adults at 18 years old, and regular blood pressure measurement are recommended in adults from age of 40 years or earlier in patient at high risk. Also, they recommended the devices used in the hypertensive patient. Automatic electronic upper arm cuff device are recommended class 1, while cuffless blood pressure device should not be used for evaluation or management of hypertensive in clinical practice. Also, in conclusion, that office blood pressure should evaluate for evaluation of blood pressure should start to measure blood pressure for first visit in the office, and for follow-up the patient, and for follow-up to management of treatment of hypertension, use home blood pressure measurement. And there is a unique diagnostic method used in selective cases, as I mentioned, ambulatory blood pressure monitoring should be used in those with secondary or resistant hypertension. Office blood pressure measurement recommend to diagnose hypertension during at least 2 separated office visits within 4 weeks, unless office blood pressure indicate grade 3 hypertension or patient presented with hypertension-related symptoms, or there is evidence of hypertension-mediated organ damage or cardiovascular disease. And in the home blood pressure monitoring, before office visit, monitoring for 7 days, more than 3 times. Take duplicated morning and evening measuring 1 minute apart, calculate the average after discarding the first day. And the ambulatory blood pressure, still the recommendation used in selected cases and mostly in the patient with secondary or those patients with resistant hypertension, and should be measuring or calculate the measuring for 20 minutes during day and night to minimize the risk of missing day or night periods. What about the targeting of the initiation of treatment? Difference number 8. In patient 18 to 79 years old, the recommended office threshold for initiation drug therapy is 140 systolic, 90 diastolic. In those with age more than 80, the recommended office systolic blood pressure 160. And in those with 65 to 79 years old group, initiation of a treatment should be considered when the systolic more than 140 and diastolic more than 90. And initiation of a treatment with 2 drug combination also recommended in most patients who are not frail. And in case to get the target, the goal to lower blood pressure in the office below 130/90 in patients with 18 years old to 64, and below 140 to systolic and 80 diastolic on those with 65 to 79 years old, and below 140, within range 140, 150 systolic, below 80 diastolic on those above 80 years old, and do not aim to target office blood pressure, systolic blood pressure below 120/70 during treatment for the additional safety recommendation. As the guidelines said, those with more than 8 years group, strategy are individualized, follow functional assessment, and most patients in this group, monotherapy should be considered as initiation therapy. What about beta blocker? Difference number 9. The randomized controlled trials and meta-analysis have demonstrated that when you comparing with the placebo, first generation and second generation beta blocker, propranolol, atenolol, and metoprolol significantly reduce the risk of stroke, heart failure, and major cardiovascular event in hypertensive patients. Difference number 10 regarding the resistant hypertension, what new? The definition is the same, but the new patient not controlled with ACE inhibitor or ARBs plus calcium channel blocker and diuretic can add another drugs according to the GFR. If the GFR more than 30, we can add spironolactone, beta blocker, central acting agent. We can consider renal denervation if GFR more than 40. And also, guideline recommended renal denervation is offered should be done in shared decision maker process after objective and complete patient information. Also should be did in experienced special center. What about update in the treatment of hypertension and heart failure with reduced ejection fraction and heart failure with the preserved ejection fraction? Different number 11. As you know, randomized control trial with carvedilol, bisoprolol, metoprolol, nebivolol improve outcome in patients with heart failure, reduce ejection fraction, added in addition to the 4 pillars. And guidelines say that in patients with hypertension and heart failure with reduced ejection fraction, It is recommended to combine drugs with document outcome benefit include IC inhibitor, ARBs, if not tolerated, which could be substituted by ARNI, beta blocker, MRA, GL2 inhibitor, if not contraindication, and well tolerated. Also, this slide shows that heart failure with a preserved ejection fraction, they recommend the treatment of hypertensive with all major antihypertensive drug classes, ACE inhibitor, ARBs, beta blocker, calcium channel blocker, thiazide like diuretic is recommended in patients with heart failure with a preserved ejection fraction. GL2 also recommended, but class 2 use of ARNI and MRA in heart failure with a preserved ejection fraction. Still, we face in practice physician inertia. Unexpected treatment inertia is much more important in real world practice, where it can be rated a major factor responsible for poor blood pressure control. Low dose aspirin is not recommended in primary prevention. Another difference between update on the latest guideline shared that the update on treatment approach to patients with type 2 diabetes, and I found that non-divert or elevated nighttime blood pressure is indicated for ambulatory blood pressure use in diabetic patient. Also, immediate lifestyle intervention and antihypertensive treatment recommended for people with type 2 diabetes when office blood pressure more than 140 and diastolic more than 90. And the primary aim to lower blood pressure in patients with diabetes below 130/80. Use of non-steroidal MRA finerenone can be used in patients with diabetes. It is used to lower the blood pressure. There is a rule in this guideline to the general physician, pharmacist, and team-based care in hypertensive clinic in those patients because this multidisciplinary and complementary action for other subspecialties to use the goal in management and control of the hypertension. There is a challenge in the follow-up and long-term patient with hypertension. Still, the difference share, and they encourage use of home blood pressure monitoring and telehealth technology to improve the care. As you know, in this busy slide, the diagnosis initial phase, short-term follow-up and long-term follow-up, according to the period time from the optimal time of blood pressure control first 3 months to the maintain optimal blood pressure monitoring or control first year, and after first year maintain optimal blood pressure control. Non-adherence, one of the major issue in the management of hypertension, and this make a difference number 15. Screening for non-adherence to treatment is recommended in patients with apparently resistant hypertension. Physicians should collect information on adherences mid-full that all methods have limitation, and several strategies can be considered to improve adherence and multidimensional team-based care approach in the recommendation. Lastly, the home message blood pressure guideline need to be focused more on implementation recommendation for accurate diagnosis and strategy for improved control in those being treated for hypertension. Published 2023 ESH guideline is update rather than deep change. Finally, I would like to thank you, and this is a picture from Baghdad, Medinat Az-Zawra. Thank you very much.